Thank CAST team for having me here in the City of Joy. At the outset, I would like to invite you to the second edition of Ahmedabad Arthroscopy Conference on 17th and 18th May this year. Please do come to the Ahmedabad city. Now let us start with the talk. So my topic is on arthroscopic meniscus repair inside out method. So this is a very nice paper if you want to study about the history of inside out repair. So it was first described by Hennings in 1983 and he did it using cannulated kite needle. He also described this posterior incision, that is safety incision for the suture retrieval, and the use of fibrin clot as Rajkumar sir described for suture healing. So tear patterns, blood supply, everything sir has covered. The inside out method, it is a oldest method, but still it is the gold standard because in our setting it is very important, the cost constraint. So we all know that it is inexpensive. Strong repair construct can be achieved using inside out repair. The versatility of the method, like we can repair huge area of meniscus starting from the posterior horn, body and some part of anterior horn. So it is very versatile technique. The reproducibility, if like you master the technique, we get the reproducible results. Technically it is less demanding. Knots, they remain outside the joint. It is very important because it irritates the cartilage, and the use of small bore needles that causes the less tissue damage, because we all know that all inside repair devices, they have a very large needle, so it can damage the meniscus. So the dilemma, should we repair all the tear using inside out? The answer is no. So these are the criteria. So I will just show it and rush it through. The essentials and biomechanics sir has already described, but this diagram is very important. When you are planning an inside out repair, the entry of the needle in the meniscus gives more strong construct because on the cyclical loading. So the red dot is showing that if your entry is in the meniscus, it gives strong construct. The blue dot at the meniscocapsular junction, it is relatively lesser strength, and with the green dot, it is even lesser strength. So the management of different tears, like with using inside out method, we can plan different meniscus repair. Like for example, if it is a radial tear, then we can plan it in a rebar configuration or a Hess type of configuration. Like anterior and posterior, we put a vertical suture and then the horizontal matrix. For horizontal tear, we can just close the fish mouth. So that is horizontal tear can be repaired. Inside out technique requires very less armamentarium. With the use of advent of zone specific cannula, we are able to cover the huge area of meniscus. Now when we talk about inside out repair, we should know the safety incision. For the posteromedial side, we have to go between the medial gastrocnemius and semimembranosus, and at the posteromedial capsule, just put the spoon or the Hennings retractor and save the posterior vital structures. On the posteromedial side, we have to protect the saphenous nerve. For the posterolateral, there are more important neurovascular structures which are there. So just split the IT band and go between the gastrocnemius head and the posterolateral corner. Now the case. So 27-year-old male without any comorbidity. He is office goer. His sports activity level is recreational. History of bike accident 3 months back. He was complaining of pain and locking. He was having on examination neutral alignment, medial joint line tenderness. Range of motion is 10 to 130 degree. McMurray's is positive. And he was having pain on passive extension. Anterior drawer and posterior drawer were negative. Varus valgus stress test was negative. Was advised X-ray and MRI. X-ray was normal and MRI picture was showing this. So any comments from the panel, like what they would like to, how they would like to plan, or any discuss? So it is a double.
It is quite obvious that your meniscus, the medial meniscus has been torn and it's been displaced.
Yes, so double PCL sign was positive, and I had plan, as sir said, like arthroscopic meniscus repair using inside out needle. So first take the safety incision, put the spoon or a Henning's retractor, and this is the arthroscopy. First the diagnostic round using your trocar or probe, just reduce the meniscus and check the reducibility, because sometimes in the chronic settings they are not reducible. So check the reducibility. Once that is done, go for the diagnostic round. Her lateral meniscus was normal. Then in the second video you have to improve the trying to improve the biology. So just debride and abrade the tear using shaver or basket punch. Once that is done, now start shooting your inside out needles. So first start with the vertical fashion. Once that is done, you will see that there is a uplifting of the meniscus, and to prevent that you have to put the suture on the inferior surface, so that will avoid the uplifting of the meniscus. Once that is done, and if you are not happy with the construct, then you can put one horizontal or two horizontal stitch as well. Using fiber wire. The post-op rehab for 0 to 4 weeks, it is non-weight bearing, range of motion, passive 0 to 90 weeks, SLR and patellar mobilization is allowed. For 4 to 6 weeks, gradual weight bearing and active range of motion is allowed, and full range of motion is allowed. For more than 6 weeks, strengthening program and gradual return to pre-injury activity. The disadvantage of inside out method is you have to take extra incision, which sometimes patient they don't ask for. Extra soft tissue dissection, extra assistant is required, extra care and extra time of surgery. Complication as discussed. So in summary, inside out method is still the gold standard. It is useful and cost saving in large tears. You have to master the technique, and slowly it will give reproducible results. Take care of soft tissue and neurovascular bundle by safety incision. Have a good assistant and keep saving the meniscus. Once again, I would like to invite to our conference